On that same topic, Neeraj, Nivo-Ipi versus Nivo monotherapy, you talked a little bit earlier about using either one in the second-line setting, for instance. What's been your experience in terms of the difference in toxicity profile between monotherapy and doublet IO therapy?
So if we compare the first-line data with the second-line data, with the big caveat that by the time patients are in the second-line setting, they may have higher volume disease, maybe indicative of better disease biology, which is allowing them to go up to second line. So a lot of caveats, different patient population. But we are not seeing the complete responses with single-agent nivolumab to the extent we see with Ipi-Nivo. So I think that's the first thing I take from this, that complete response. For complete responses, the whole point we do immunotherapy for EP is necessary. That's the efficacy perspective. But from toxicity perspective, we see really exponential increase in toxicity with combination of EP and Nivo. So I think it's a balancing act. Where is the line where we look at is a balancing act, I think, for each of these patients. So second line setting, I tend to go with nivolumab alone because that's a data. Even though NCCN guidelines allow us to use Ipi-Nivo in second line, but based on the data, I tend to use nivolumab alone in second line.
Brad, looks like you had a thought on that.
Yeah, I mean, I think this is the idea of like nivolumab or nivolumab. What's one of the critiques of Checkmate 214 is that there's no single agent nivolumab arm and less than 30% crossover immunotherapy. And so, I mean, I think that's an important question to ask. And so we actually have a phase 2 clinical trial called Omnivore, which is trying to look at this very question. So we start patients with nivolumab monotherapy, and then based on response, we will add in ipilimumab. So if those patients don't have a PR after 8 weeks of therapy, then they'll sort of try to rescue with ipilimumab, if you will, to see if like we can, there's those patients that may, nivolumab, like PD-1 blockade alone may be sufficient, and we can sort of limit the toxicities of ipilimumab in those patients and only offer it to those patients there. And so that's ongoing, and I think it'll ask a very important question.
Yeah,
I really like that. So sometimes we're able to add in the Ipi for nivolumab, patients progressing on nivolumab and salvaging, that may not be responding as well. And so this way you're collecting these prospectively studied patients, and I think that's a great trial for patients to be on.
I'm like, you are leading a trial, Tian, very similar response adaptive design, and I think that's the future. That's going to happen. We know that not every regimen is right for every patient, right?
Sure.
So tell me about your trial. How does it?
Yeah, absolutely. So we had this is you're absolutely right. It's an adaptive phase 3 trial that we're leading out of the Alliance Cooperative Group. It will likely open this May, but it's a very large trial that is enrolling intermediate poor risk metastatic clear cell kidney cancer patients. We're starting with that induction that's really basing off the Checkmate 214 regimen. So 4 cycles, but up to 4 cycles of ipilimumab, nivolumab. If people get into toxicity issues in the first 2 or 3 cycles, they can skip the last 1 or 2 cycles. And then based on that response on that first 3-month imaging, we're adapting the trial to the arm of the treatment that they're going to subsequently receive. So the complete response patients, they really don't need any added toxicities. Those patients should get nivolumab alone per Checkmate 214. The patients who have progressive disease, those patients really shouldn't be on nivolumab monotherapy, and so those patients are going on to receive cabozantinib alone. So we'll have some sequencing data there as well. And then everyone in between, so the non-complete response, non-progressive disease patients, so anyone with a stable disease or even some of the partial responses, those patients will be randomized to either receiving nivolumab alone or the combination of nivolumab and cabozantinib. And so we're really excited about this trial, and I'm really glad to have support throughout all of the cooperative groups, including ECOG and SWOG. And we hope that we'll be able to think about when is the right time to add in that VEGF combination while still capitalizing on the complete responses that ipilimumab, nivolumab can give us. So our overall, the primary endpoint of our study is overall survival. And then there's some key secondary endpoints that I really like. So there's progression-free survival, but there's also 1-year complete response rates. So we're really hoping to improve the complete responses that we see from Checkmate 214. And that 1-year complete responses, when patients get to that 1-year mark, we're actually putting in part of the trial is to discontinue treatment for those patients. And so when that happens, if we can follow these patients and see, are these patients, do they have durable responses off treatment? Who recurs, why, what are there patient characteristics that we can figure out who will have early recurrences off treatment. I think all of those are pretty clinically useful and meaningful questions for us to think about as a community.
That's great, Tian. And let's end this portion of the discussion on a high note, talking about that CR population. If you get a CR with Nivo and Ipi, what was the rationale behind stopping at that 1-year mark?
We really have very limited data in this setting, and so it's really about limiting the toxicities that we've been discussing quite a bit, and those toxicities that are immune mediated can happen at any point during a patient's treatment, and so from our clinical experiences, we have been stopping patients at 1 year of complete responses. Some of them have, most of my patients have not recurred yet, but again, we have very short follow-ups of these patients since we've only adapted using these regimens in the last 2 years. So as time goes on, we'll learn more about that, and I think this is a way that we can prospectively study that endpoint of 1 year of complete response.
I think it has to be some sort of landmark, so 1 year sounds reasonable to me.